Welcome to part 3 of our diabetes series. Now that we've covered the presentation and management of diabetes, it's time to focus on the chronic complications of diabetes. We'll cover each complication in mini soap style, meaning we'll discuss the presentation, diagnosis, and management of each complication individually. Complications related to diabetes are predominantly related to the consequences of chronic hyperglycemia, and these are divided into two major categories: microvascular and macrovascular complications. To evoke an image of chronic hyperglycemia, we've drawn in a recurring symbol for chronic disease, a chronic grandfather clock, this time covered in sugary treats. Because hyperglycemia is the driving force behind these complications, glycemic control is extremely important. Therefore, we monitor these patients and their response to treatment closely. To represent the micro and macrovascular complications of diabetes, let's draw in King Candy's favorite pet, a red vascular candy snake. The major microvascular complications are nephropathy, retinopathy, and neuropathy, represented by that narrow diameter tail. Macrovascular complications, on the other hand, include coronary artery disease, cerebrovascular disease, and peripheral arterial disease, represented by that large diameter head. Let's talk about the microvascular complications in more detail, starting off with diabetic kidney disease. Diabetic kidney disease typically develops after about 10 years in type 1 diabetes, but may present at diagnosis in type 2 diabetes. Diabetic kidney disease is the number one cause of end stage renal disease in the United States, but it doesn't develop overnight. Though it seems counterintuitive, the earliest renal abnormality in patients with diabetes is, in fact, glomerular hyperfiltration, leading to increased GFR. So we've turned this grounds filtration rate coffee machine to full blast. This phenomenon is more common and more pronounced in type 1 diabetes compared to type 2. Although it's not fully understood, it's thought that this occurs due to dilation of the afferent arteriole, which increases intraglomerular pressure. This increased pressure likely contributes to glomerular damage and progression of diabetic nephropathy. Chronic hyperglycemia also plays a role, promoting the formation of glycation end products, which results in the local release of inflammatory mediators, reactive oxygen species, and growth factors. All in all, small vessels start changing. In the glomerulus, glomerular basement membrane thickening can be seen, as depicted by the thickened purple stripe on this knotted glomerular tail. Mesangial expansion also occurs, with characteristic Kimmel-Steele-Wilson nodules, hence the pink nodular candy that's embedded in there. And thirdly, diabetic nephropathy is characterized by progressive glomerulosclerosis. Sclerosis meaning hyaline deposition in the capillary wall, leading to capillary ablation. In this scene, sclerosis is represented by that sclerotic scaly snake tail. Over time, these glomerular changes lead to proteinuria and a reduction in GFR. In the long run, that means progressive chronic kidney disease for many patients, as depicted by this shriveled kidney-shaped raisin. Alright, well, that's all fine and dandy. But how do these stages of diabetic kidney disease present clinically? Let's start with vitals, specifically blood pressure. Hypertension is common in patients with diabetes, but the timing is a bit different in the setting of type 1 versus type 2 diabetes. In patients with type 1 diabetes, blood pressure doesn't really begin to rise until after the first signs of renal disease. As we'll detail in a moment, the first sign of renal disease is a moderately increased albuminuria. A few years later, blood pressure starts to rise and continues to increase as renal disease progresses. Patients with type 2 diabetes are a little different. As many as 40% will already have hypertension at the time of diagnosis. Many of these patients will have developed hypertension before any signs of renal disease. This underscores the pathogenesis of type 2 diabetes, which occurs in patients with obesity and insulin resistance, both of which are also known to contribute to the development of hypertension. In summation, it's a two-way street. Diabetic kidney disease causes hypertension to develop, and hypertension is a strong risk factor for the development and progression of diabetic kidney disease. It's a vicious cycle. Besides diabetic nephropathy, hypertension is also thought to be related to increased sodium retention at the kidney and increased vascular stiffness. Regardless of pathogenesis, however, it's clear that treating hypertension can slow the progression of kidney disease. Let's look at labs. Patients with diabetes are routinely screened for diabetic nephropathy, the earliest sign of which is a moderately increased albuminuria, formerly referred to as microalbuminuria. It's defined as a persistent albumin excretion between 30 and 300 milligrams on a 24-hour urine collection. In this scene, moderately increased albuminuria is represented by this family album here, sitting in the filtered water leak. Notice that the Earl of Donut looks like the number 30, while the picture of King Duncan behind him adds another zero to make 300. The sun on the floor represents 24 hours. That's 30 to 300 milligrams albumin on a 24-hour urine collection. However, no one wants to sit around collecting a urine sample all day. So, in clinical practice, a spot urine albumin to creatinine ratio can be measured from a random urine sample. So, we've added our recurring creatinine credit card symbol underneath the Earl of Donut. Part of the annual screening of a diabetic patient includes this test. A urine albumin to creatinine ratio greater than 30 is considered moderately increased albuminuria and warrants further management. I want to point out here that testing the urine for the microalbumin creatinine ratio is not the same as a dipstick test of the urine for protein. The dipstick test can only detect excessive urinary protein excretion above 300 milligrams per day. Spurious results also occur because this test can be affected by urine volume. Suffice it to say, dipstick is not useful for screening in the early phases of diabetic kidney disease. Speaking of excessive urinary protein, moderately increased albuminuria can progress to severely increased albuminuria, formerly called macroalbuminuria or overt proteinuria. This is defined as an albumin excretion above 300 milligrams per day on a 24-hour urine sample, or a urine albumin to creatinine ratio above 300 on a random sample. The development of severely increased albuminuria is usually accompanied by a progressive decrease in GFR. Look for a rising BUN and creatinine, suggesting development of chronic renal disease. Chronic kidney disease is defined as the presence of kidney damage, such as albuminuria, or decreased kidney function, that is, decreased estimated GFR, for 3 or more months. If your patient has CKD, calculate the stage. Check out our chronic kidney disease sketch at the Natural History Museum for all the details. As you can see, the vast majority of cases of diabetic kidney disease are diagnosed clinically by the presence of albuminuria in a patient already diagnosed with diabetes. Renal biopsy to confirm the pathologic findings of diabetic nephropathy is very rarely necessary. That said, other causes of chronic kidney disease should be considered in certain circumstances. Here are some clues that you're dealing with something other than diabetic kidney disease. First of all, diabetic nephropathy is a slow progressive disorder. If patients show rapid progression of their renal disease, think about other etiologies. Similarly, diabetic kidney disease typically doesn't lead to severe hypertension. Therefore, a patient who has evidence of kidney disease and refractory hypertension should make you think of other causes of CKD. Additionally, diabetic nephropathy often occurs with diabetic retinopathy. If nephropathy occurs in the absence of retinopathy, keep other causes of CKD on your differential. One sensitive feature to look for is the presence of active urinary sediment on urinalysis. Cells, casts, or other abnormalities on sediment analysis point away from diabetic kidney disease, which typically only produces albuminuria. Specifically, nephrotic range proteinuria and oval fat bodies or fatty casts on sediment are indicative of nephrotic syndrome, whereas hematuria, dysmorphic red blood cells, and red blood cell casts are characteristic of glomerulonephritis. Meanwhile, the presence of eosinophils and white blood cell casts on UA suggest interstitial nephritis. Lastly, a significant reduction in GFR after initiation of an ACE inhibitor or ARB is suggestive of bilateral renal artery stenosis. Refractory hypertension is another clue that renal artery stenosis is to blame for your patient's chronic kidney disease. For patients with any of these features, referral to a nephrologist may be necessary, and a kidney biopsy may be indicated for definitive diagnosis. All right, let's summarize the clinical presentation of diabetic kidney disease in a sample assessment statement. Mr. Cadbury is a 58-year-old man with a 20-year history of hypertension and a 7-year history of type 2 diabetes. He was referred for further evaluation after testing at his PCP's office showed a urine albumin to creatinine ratio of 180. His home meds include metformin, glipizide, lisinopril, and hydrochlorothiazide. A hemoglobin A1C performed last month was 6.9%. Today, his blood pressure in the office is 148 over 90. Physical exam is significant for fundoscopic findings consistent with diabetic retinopathy and unchanged from last year's exam. UA is significant for a few red blood cells and 1 plus protein. Other labs, including BUN and creatinine, are normal. Mr. Cadbury's albuminuria, in the setting of his long-standing diabetes, is concerning for new diabetic nephropathy. Once you've made the diagnosis of diabetic kidney disease, there are specific measures you should take in order to preserve your patient's renal function. In accordance with the King Candy's mantra, the first step in the management of diabetic kidney disease is optimal glycemic control, with the goal of achieving near normoglycemia. In fact, as we'll soon illustrate, glycemic control is central to reducing the risk and progression of all the micro and macrovascular complications we'll cover in this sketch, which is why this mantra is emblazoned above the micro and macrovascular ends of that candy snake. Focusing on those kidneys, remember that optimal glycemic control can delay the onset and progression of albuminuria and reduce GFR in patients with diabetes. Once overt proteinuria develops, however, glucose control has less effect on the course of nephropathy. Control of hypertension is also essential for preventing development and progression of diabetic kidney disease. According to the 2017 AHA guidelines, blood pressure goals for most patients with hypertension are less than 130 over 80, and the goal for diabetics is no different. In non pregnant patients with diabetic kidney disease and hypertension, an ACE inhibitor or an ARB is recommended as the first line antihypertensive therapy for those with at least moderately increased albuminuria, a urine albumin to creatinine ratio greater than 30, in other words. These medications decrease glomerular pressure, which slows progression to more advanced proteinuria and reduces cardiovascular events. ACEs and ARBs are also recommended in patients with more advanced diabetic nephropathy. In other words, a urine albumin to creatinine ratio greater than 300 and or a GFR less than 60, as they slow progression even in more advanced disease. A couple extra points to add. While ACE inhibitors or ARBs are often prescribed for albuminuria without hypertension, there is no clear evidence that this improves renal outcomes. Also, if a patient with diabetes has hypertension but no signs of diabetic nephropathy, ACE inhibitors or ARBs are an option, but not necessarily superior to the usual go-to classes of antihypertensive therapy. A thiazide or calcium channel blocker will do the trick. Let's now move on to another complication you're likely to see: diabetic retinopathy. This is the most common cause of blindness in middle-aged patients. Diabetic retinopathy is a highly specific microvascular complication of diabetes. Its development is strongly related to both the duration of diabetes and the level of glycemic control. Other factors associated with diabetic retinopathy include hypertension and dyslipidemia. There are two types of diabetic retinopathy: non-proliferative and proliferative. Non-proliferative retinopathy accounts for the majority of cases. It'll be illustrated on this retinal hard candy. It's characterized by a variable display of pathologic changes within the retina, including infarction, hemorrhage, exudates, and microvascular abnormalities. Vision loss in the setting of diabetic retinopathy is primarily due to macular edema, which can occur at any stage of diabetic retinopathy. It's caused by capillary leakage into the retina and can be seen on a specialized fundoscopic exam as retinal thickening and edema in the area of the macula. Just think of this edematous fluid here, causing this retinal wrapper to become thickened. Non-proliferative retinopathy, especially when severe, can lead to a proliferative retinopathy. Why? Well, vascular occlusion and subsequent retinal ischemia that occurs in the setting of non-proliferative disease causes the local release of vasoproliferative factors, such as VEGF. Just think of this VEGF veggie here being dragged away to some kind of sugary torture chamber, probably to get diced and caramelized. Notice those vascular roots dangling from his spindly root legs. These vasoproliferative factors promote new blood vessel formation in the optic disc and retina, which characterizes proliferative retinopathy. These abnormal retinal vessels are prone to bleeding, which typically causes transient vision loss. Neovascularization can also cause traction retinal detachment, which can lead to permanent visual loss. Let's get into the clinical presentation. Diabetic retinopathy is usually asymptomatic until the late stages of the disease, which is why screening is so important. Notice that this jelly bean minion here is happy and symptom free as he cleans the king's prized hard candy collection. Patients with symptomatic diabetic retinopathy most commonly report the gradual onset of decreased visual acuity. It's typically noticed with both near and far vision and cannot be corrected with refraction. This is a sign of macular edema, which, as we described earlier, is caused by capillary leakage into the retina and can occur at any stage of diabetic retinopathy. Retinal detachment in the setting of proliferative retinopathy may present with painless unilateral vision loss, visual field defects or blind spots, as well as a loss of visual acuity if the macula is involved. Vitreous hemorrhage in the setting of proliferative retinopathy typically presents with floaters or shadows if the hemorrhage is mild. There may be severe painless vision loss with more severe hemorrhage. In general, these changes in vision are only transient. And finally, those rock hard eye candies are meant to evoke an image of glaucoma. You see, new vessel proliferation can occur in the anterior chamber as well, leading to obstruction of the outflow path for aqueous humor. The increase in intraocular pressure is often acute and painful, with diffuse conjunctival injection and blurry vision in the affected eye. Just look how cranky that eye is. Alright, let's talk about the physical exam, specifically the fundoscopic exam. Non-proliferative retinopathy is associated with microaneurysms, retinal hemorrhages, so-called hard exudates, which involve leakage of lipid and proteinaceous material, and lastly, cotton wool spots, which are pale patches that indicate nerve fiber infarcts. The edema and retinal thickening associated with macular edema can be visualized with specialized fundoscopic imaging, including stereoscopic viewing, fluorescein angiography, and optical coherence tomography. Proliferative retinopathy is diagnosed by visualization of new vessel formation within the retina. Fluorescein angiography helps detect leakage from these newly formed vessels. Look for signs of retinal detachment as well, such as distortion of retinal anatomy. Vitreous hemorrhage on fundoscopic exam may appear as a loss of detail and floating debris, or even as a totally obscured field with a red glow in the setting of significant hemorrhage. Let's summarize the presentation of diabetic retinopathy in a sample assessment statement. Opal Eyes is a 46-year-old woman with type 2 diabetes presenting for a routine checkup. She was diagnosed with diabetes 1 year ago on routine screening. Her most recent hemoglobin A1C performed last week is 7.8%. Her home meds include metformin and lisinopril. Physical exam today is significant only for multiple microaneurysms and hard exudates bilaterally on fundoscopy. No macular edema is noted. Vital signs and other labs obtained are unremarkable. Miss Opal's exam findings are consistent with non-proliferative diabetic retinopathy. So you found diabetic retinopathy. After you're done patting yourself on the back for actually seeing something through the ophthalmoscope, it's time to do something about it. Optimal glycemic control reduces the risk and progression of the micro and macrovascular complications of diabetes, and this includes diabetic retinopathy. As emphasized by this little bean man with high pressure steam and a stick of butter, blood pressure control and serum lipid control have also been shown to reduce the risk and progression of diabetic retinopathy. Most patients with non-proliferative retinopathy are not treated unless accompanied by clinically significant macular edema. Since the edema is being caused by leaky vessels, intravitreal VEGF inhibitors, like bevacizumab, are the preferred therapy, represented here by this anti-vegetable notice. A warning to all health foods who dare trespass on King Candy's domain. For patients with proliferative retinopathy, laser photocoagulation is the treatment of choice. It preserves remaining vision, reduces the rate of progression, and can be used to repair vascular lesions. Intravitreal VEGF inhibitors, like bevacizumab, are also used. They have been shown to reduce the risk of vision loss in patients with proliferative disease. Alright, let's move on to probably the most common microvascular complication in the setting of diabetes: diabetic neuropathy. The most important risk factors for the development of diabetic neuropathy are related to the duration and severity of hyperglycemia. The pathophysiology of neuropathy is multifactorial, with accumulation of advanced glycosylation end products, osmotic nerve swelling due to sorbitol accumulation, and sclerosis of endoneurial blood vessels all playing a role. Diabetic neuropathy most commonly manifests as a distal symmetric polyneuropathy. It primarily involves a loss of sensory axons with damage to the longest axons first. This leads to a progressive loss of distal sensation, which starts in the lower extremities and later involves the hands in a classic stocking glove distribution. In severe cases, motor axonal loss can occur, presenting as weakness in a similar distribution. Keep in mind that polyradiculopathies and mononeuropathies can occur as well. The most common mononeuropathies affect the median and cranial nerves, especially cranial nerves 3, 4, and 6, the oculomotor, trochlear, and abducens nerve. I mean, just look at this guy. Definitely some kind of oculomotor nerve palsy going on. Diabetic neuropathy also frequently involves the autonomic nervous system. This leads to dysfunction of organs like the GI tract, bladder, and cardiovascular system, which rely on autonomic input to function. All right, let's see what this means for our patient. Diabetic polyneuropathy can present with negative symptoms, such as numbness, as well as positive symptoms, such as tingling and pain. This typically occurs in the distal lower extremities first, and later involves the hands in that classic stocking glove distribution, as illustrated by the stockings and gloves worn by this neuropathic gingerbread man. Remember that weakness can occur as well, especially in severe disease. Let's highlight those positive pain symptoms by adding a flame to his foot. Diabetic neuropathic pain affects many patients and is characterized by tingling, burning, sharp, or electric shock like pain. The pain can even be constant and accompanied by allodynia, which manifests as severe pain from minor stimuli that do not normally provoke pain, such as a light touch. Neuropathic pain can substantially affect the quality of life of patients with diabetes, and as we'll discuss shortly, there are specific treatment strategies we can pursue. Large fiber neuron loss results in diminished pressure sensation and proprioception, which predisposes patients to imbalance and falls, as illustrated by his top heavy friend. Autonomic neuropathy can impair gut motility and cause gastroparesis, presenting with chronic nausea and vomiting and early satiety. Delayed gastric emptying can also lead to hypoglycemic episodes if insulin is administered prior to meals, since digestion and absorption are impaired. Involvement of parasympathetic nerves can also cause neurogenic bladder. Decreased ability to sense a full bladder leads to urinary retention. Eventually, urinary retention leads to overflow incontinence and recurrent UTIs. Ask your patient about reduced urination, poor urinary stream, and incontinence. In men, involvement of parasympathetic nerves can also cause erectile dysfunction, though keep in mind that there are numerous potential causes of erectile dysfunction, including alcohol consumption, endocrine dysfunction, depression, psychogenic disorders, vascular disease, and meds. Autonomic neuropathy can also cause postural hypotension. This is a consequence of central and peripheral cardiovascular sympathetic denervation, which results in failure of vasoconstriction in both the splanchnic and peripheral vascular beds. In severe cases, orthostatic hypotension can cause significant drops in blood pressure, resulting in syncope. Other signs of cardiovascular autonomic neuropathy include resting tachycardia and exercise intolerance. Time for the physical exam. Start with a complete sensory and motor exam. Test small fiber nerve function by assessing pinprick and temperature sensation. Test large fiber nerve function by assessing vibration perception using a 128 Hz tuning fork. You should also perform a 10-gram monofilament test, in which a 10-gram monofilament is placed on the plantar surface of the foot at a right angle. Pressure is increased until the filament buckles, and the patient is asked if they can feel the pressure. Failure to detect monofilament pressure indicates a so-called loss of protective sensation, or LOPS, which correlates with increased risk of foot ulcer formation. Speaking of, while you're down there poking around, perform a complete foot exam. Let this crumbly hole in his foot remind you to check for ulcers, which can be secondary to dermal abrasion from poorly fitting shoes, for example, or more chronic in nature, developing over weight-bearing areas. Ulcers form due to a combination of decreased pain sensation in the foot, muscle imbalance leading to distorted anatomy and pressure points, and vascular insufficiency causing impaired skin integrity and wound healing. Ulcers can become infected and even lead to osteomyelitis. Check out our foot ulcer sketch over in our sketchy surgery course for more details. Besides ulcers, perform a general inspection of the foot, noting the presence of dry or cracking skin, fungal infection, or calluses and blisters. Not only that, notice that we've made the remaining foot kinda claw-like. Inspect the foot for any anatomical deformities, including claw-toe deformity. which is caused by atrophy of the intrinsic foot muscles, resulting in an imbalance between extensors and flexors. This shifts weight to the metatarsal heads and predisposes to ulcer formation. Also, you see that chocolate leaking out of his foot? It's our symbol for neurogenic arthropathy, also called Charcot joint. When patients lose sensation to a weight bearing joint, microtrauma can occur over time, resulting in a progressive and destructive arthropathy. Patients may present with warmth, redness, and edema of the affected joint. Or, in more chronic presentations, abnormal bony prominences and deformities of the foot and ankle develop. The tarsal and tarsometatarsal joints are most frequently involved, resulting in collapse of the arch of the midfoot. The metatarsophalangeal joints and ankle are also commonly affected. Bony deformities predispose patients to ulcer development. The comprehensive foot exam should also include a vascular assessment. This includes palpation of foot pulses, which will be decreased in the setting of peripheral artery disease. All right, let's wrap up our physical exam. Check those reflexes. Early in the course of diabetic neuropathy, patients may have diminished or absent deep tendon reflexes at the ankles due to defects in the sensory portion of this reflex. To assess balance and fall risk, have your patient perform normal gait, tandem gait, and a Romberg test. A positive Romberg test occurs when the patient sways or falls while standing with feet together, eyes closed, and hands at the side. Also, remember that mononeuropathies can occur as well. The most common peripheral mononeuropathy involves the median nerve. The most common cranial mononeuropathies involve the nerves to extraocular muscles, cranial nerves 3, 4, or 6, in other words. So make sure to do a full cranial nerve exam and assess for unilateral pain, ptosis, and diplopia. In patients with suspected neurogenic bladder, palpate for a distended bladder, get a urinalysis, and get a bladder ultrasound to measure a post-void residual urine volume, which is typically over 50 milliliters in a patient with urinary retention. Typically, though, the most common form of diabetic neuropathy is distal symmetric polyneuropathy. And it's true, diabetes is the most common cause of distal symmetric polyneuropathy. However, there are a bunch of other causes of polyneuropathy that are relatively common, even in patients with diabetes. So, if your patient's complaining of pain and paresthesias in their feet, make sure to consider these other causes of distal symmetric polyneuropathy as well. First, use your history taking skills to rule out alcoholic polyneuropathy, the second most common cause of distal symmetric polyneuropathy. A history of significant alcohol use should raise red flags that diabetes might not be to blame. While you're at it, get a detailed medication history and look for drugs associated with polyneuropathy. Classic ones include chemotherapy agents like vincristine and cisplatin, as well as isoniazid when given without vitamin B6. Moving on. If your patient's complaining of polyneuropathy, make sure to ask about a family history of foot issues. Deformities such as high arches or hammer toes suggest an inherited cause of polyneuropathy, such as Charcot-Marie tooth disease. When you're working up the cause of polyneuropathy, make sure to get some labs to rule out nutritional deficiencies such as vitamin B12, B6, and folate. Likewise, screen for infections such as HIV and hepatitis B and C, as they are well known to cause polyneuropathy. In addition, medications used to treat HIV can also cause neuropathy, so double whammy. Next, a serum protein electrophoresis can distinguish neoplastic causes, such as multiple myeloma, from diabetic neuropathy. Don't forget about the biggies, chronic kidney and liver disease. These conditions are super common, but neuropathy associated with them is not. Either way, history and labs will help you distinguish between neuropathy associated with CKD or liver disease and diabetic neuropathy. And finally, in patients with other features of autoimmune diseases, such as rheumatoid arthritis or Sjogren's syndrome, order screening labs such as an ANA and rheumatoid factor to distinguish those conditions from diabetic neuropathy. In addition to these conditions, if there's anything atypical about your patient's presentation, such as acute onset, asymmetry, or predominant motor involvement, that's yet another clue that diabetic neuropathy may not be what's going on. All right, let's summarize the presentation of diabetic neuropathy in a sample assessment statement. Polly Parker is a 66-year-old woman with long-standing type 2 diabetes presenting with pain and paresthesias of both feet. These symptoms are not associated with muscle weakness, back pain, or bowel and bladder problems. Her only home medication is metformin, and she does not drink alcohol. She was diagnosed with diabetes 15 years ago, and her most recent hemoglobin A1C 4 months ago is 7.8%. Physical exam is significant for loss of pinprick and temperature sensation in both feet up to the ankles, loss of pressure and vibration sensation on the plantar surfaces of both feet, and loss of ankle jerk reflexes bilaterally. The rest of her exam is unremarkable, with no ulcers, deformities, or gait abnormalities noted. Polysymptoms are most likely due to diabetic neuropathy. The initial step in the management of diabetic neuropathy is, say it with me now, optimization of glucose control. This has been shown to prevent or delay the development of neuropathy in patients with type 1 diabetes and slow the progression of neuropathy in patients with type 2 diabetes. All patients with diabetes, but especially those with peripheral neuropathy, should be educated on the risk of developing foot ulcers. Patients should be checking their feet daily, avoiding activities that can injure the feet, and wearing proper footwear. For patients with neuropathic pain, there are a number of effective medications. First line therapy typically involves a neuromodulatory antidepressant, such as a dual serotonin norepinephrine reuptake inhibitor or tricyclic antidepressant, or a GABAergic medication, such as gabapentin or pregabalin. Oftentimes, multimodal combination therapy is needed. King Candy's prepubescent nephew represents pregabalin and gabapentin, GABAergic drugs that modulate voltage gated calcium channels in the CNS, preventing the release of excitatory neurotransmitters. They're also thought to affect ascending norepinephrine and serotonin pain pathways from the brainstem to the spinal cord. In practice, you'll see gabapentin used much more frequently, though its use for neuropathic pain is technically off label. Duloxetine is a dual serotonin and norepinephrine reuptake inhibitor, represented here by the happy face serotonin ball next to the North Compass norepinephrine ball. Tricyclic antidepressants are another class of agents used to treat neuropathic pain, represented by the tricycle. Keep in mind that tricyclics are typically avoided in the elderly and patients with cardiovascular disease. Gastroparesis is treated with a combination of dietary modifications, like increased fiber and small frequent meals, and medications. Metoclopramide, symbolized by those metal clogs, is useful for symptomatic relief because it has both prokinetic and antiemetic properties. And that does it for diabetic neuropathy. Why the birthday candle, you ask? Well, it's our recurring symbol for annual screening. Once a year, patients with diabetes should be screened for microvascular complications. This includes a urine albumin to creatinine ratio to assess for diabetic kidney disease, a dilated eye exam to look for retinopathy, though this can be spaced out to every 1 to 2 years if the initial exam is normal, and a comprehensive foot exam to look for development of foot ulcers. The annual comprehensive foot exam should include inspection for skin defects and foot deformities, a neurological assessment with monofilament test, and at least one other neurological assessment: vibration, pain, or temperature. The comprehensive foot exam should also include a vascular assessment with palpation of foot pulses. In general, diabetic patients have an increased susceptibility to infection because of a combination of host factors. Peripheral neuropathy increases the risk of ulcer formation, autonomic neuropathy causes urinary retention and UTI. Vascular insufficiency causes local tissue ischemia, and on top of that, there's a hyperglycemia related impairment of immune system function, including impaired neutrophil function. As a result, patients are at increased risk of a variety of bacterial and fungal infections, skin and soft tissue infections, as well as genitourinary, gastrointestinal, and respiratory infections. We'll highlight a couple classic ones here. Malignant external otitis is an infection of the external auditory canal and skull base classically associated with diabetes. This is considered an ENT emergency. It pretty much only occurs in elderly patients with diabetes, though other immunocompromised patients are also at risk. Malignant external otitis is caused by Pseudomonas in the vast majority of cases, which is why Queen Candy looks like our recurring symbol for Pseudomonas. Mona Lisa, of course. Patients present with otalgia and otorrhea. The pain can also involve the temporomandibular joint, resulting in pain with chewing. Bust out the otoscope, and you'll typically find granulation tissue in the inferior portion of the ear canal at the bony cartilaginous junction. If the infection spreads, it can cause osteomyelitis of the skull base and TMJ. Not good. Cranial nerve palsies can also develop. A characteristic, though nonspecific lab finding is an elevated ESR and CRP. If there's ear discharge, swab it and send a specimen for gram stain and culture for bacteria and fungi. A CT or MRI can help you localize disease, look for bony erosion, and monitor resolution. Treat with an anti-pseudomonal antibiotic. Oral ciprofloxacin is the agent of choice, or an anti-pseudomonal beta-lactam if the strain of Pseudomonas is resistant. Immunocompromised patients, including patients with diabetes, are also at risk of developing mucormycosis, an invasive infection caused by the Mucorales order of fungi, including the genre Mucor and Rhizopus. The most common presentation in diabetics is termed rhino-orbital cerebromucormycosis, caused by the genus Rhizopus. Hence the king's raspberry candy bird companion. Whew, seems to be developing some kind of acute infection in his giant beak sinuses. Poor guy. When susceptible patients breathe in the spores, which are ubiquitous in the environment, they take root in the paranasal sinuses and respiratory tract and invade the vasculature with their hyphae. The Rhizopus genus thrives in high glucose and acidic conditions, so rhino-orbital cerebromucormycosis is actually most commonly seen in diabetic ketoacidosis. So we've brought back our DKA candy key, unlocking the Rhizopus cage. Expect the acute onset of symptoms, including nasal congestion, purulent nasal discharge, sinus pain, and headache. Extension of the infection beyond the sinuses into surrounding structures is common. Orbital involvement can cause proptosis and decreased vision. Cavernous sinus and brain involvement can cause cranial nerve palsies, like ophthalmoplegia and facial numbness, as well as mental status changes and obtundation. Expect signs of systemic infection, such as fever. Workup involves sinus endoscopy with biopsy and culture. On endoscopy, the infected tissues may appear necrotic. Necrosis can spread to the palate, orbit, and brain. While culture commonly reveals growth, histopathological inspection of the biopsy specimen should reveal characteristic broad, non-septate hyphae with right angle branching. Treatment involves surgical debridement of necrotic tissue. Empiric therapy typically consists of IV amphotericin B. Management of contributing risk factors is also important. So treat that severe hyperglycemia and metabolic acidosis of DKA. Alright, let's wrap up this sketch with a brief discussion of the macrovascular complications of diabetes. Atherosclerotic cardiovascular disease, including coronary artery disease, cerebrovascular disease, or peripheral arterial disease, is the leading cause of morbidity and mortality for individuals with diabetes. Just think of this gunky red can of paint evoking an image of arteries clogged with that sweet lipidy goo. Common conditions coexisting with type 2 diabetes, such as hypertension and dyslipidemia, are clear risk factors for atherosclerotic cardiovascular disease, and diabetes itself confers independent risk. There's a high incidence of coronary artery disease, or CAD, among patients with diabetes. Not only that, diabetics tend to develop particularly severe CAD, and myocardial infarction is more extensive and more severe than in non diabetic patients. Diabetics also develop diffuse calcification of their arteries, which further contributes to coronary disease. For these reasons, coronary artery disease is the most common cause of death in patients with diabetes, which is why we've put a skull on the king's clogged coronary crown. There should be a low threshold for ordering troponin because patients with diabetes are more likely to present with a silent or atypical presentation of MI due to sensory neuropathy. For more information on the clinical presentation of coronary artery disease, check out our cardiology unit. Peripheral arterial disease occurs in up to 60% of diabetic patients. It classically presents with intermittent claudication, which is characterized by cramping leg pain that's reliably reproduced by walking the same distance and relieved by rest. However, diabetic neuropathy can mask the pain of peripheral arterial disease, allowing it to silently progress to critical leg ischemia. It's also important to keep in mind that diabetics can present with a falsely normal or elevated ankle to brachial index due to calcification of their arteries, which makes the arteries non-compressible. Check out our peripheral artery disease sketch for all the gunky details. Patients with diabetes also suffer from a high rate of strokes. Diabetes is an important risk factor for lacunar or small vessel ischemic strokes specifically. Management of atherosclerotic cardiovascular disease in patients with diabetes revolves around improving the underlying risk factors. This means glycemic control, blood pressure control, and lipid control, all covered in our cardiology unit. All patients with diabetes and ASCVD should be on antiplatelet therapy, usually aspirin, and all smokers should be advised to quit smoking. Welp, that brings us to the end of part 3 in our series on diabetes. I think we have time for a quick sum up. What do you say? Diabetic kidney disease starts off with hyperfiltration, then moderately increased albuminuria, which means over 30 milligrams per day, and then there's severely increased proteinuria, which is over 300 milligrams per day. Albuminuria is accompanied with a decrease in GFR and a rising BUN and creatinine, suggesting the development of CKD. Biopsy is only performed when the cause of kidney disease is uncertain and a definitive diagnosis is needed. Expect to see a thickened basement membrane, glomerulosclerosis, and nodular mesangial expansion. Diabetic kidney disease causes hypertension to develop. When renal function declines, blood pressures rise. Not only that, hypertension increases the risk and progression of diabetic nephropathy. Blood pressure control and glycemic control have been shown to reduce the risk and rate of progression of diabetic kidney disease. Give an ACE inhibitor to patients with hypertension and at least moderately increased albuminuria. All right, diabetic retinopathy. The non-proliferative version is characterized by microaneurysms, retinal hemorrhage, hard exudates, cotton wool spots, and vision loss, which is typically caused by macular edema. And then there's the proliferative version, which typically arises because of retinal ischemia caused by non-proliferative retinopathy. Proliferative retinopathy is characterized by neovascularization, which can lead to vitreous hemorrhage, retinal detachment, and glaucoma. Glycemic control, blood pressure control, and lipid control have all been associated with decreased risk and progression of diabetic retinopathy. Treat macular edema or proliferative retinopathy with VEGF inhibitors. Laser photocoagulation is used to treat proliferative retinopathy. Next up, neuropathy. Diabetic neuropathy typically presents as a distal symmetric polyneuropathy with sensory loss in a stocking glove pattern. This can be associated with severe neuropathic pain as well. Diminished pressure sensation and proprioception predisposes patients to falls. Loss of protective sensation predisposes patients to ulcers. Loss of sensation to weight-bearing joints predisposes patients to fractures and bony deformation. Loss of deep tendon reflexes at the ankles occurs early in the course of disease. Radiculopathies and mononeuropathies can occur as well, especially of the median nerve and cranial nerves 3, 4, and 6. Autonomic neuropathy can present with orthostatic hypotension and resting tachycardia, gastroparesis, urinary retention, or impotence. The best way to reduce the risk and progression of diabetic neuropathy is with glycemic control. Treat neuropathic pain with pregabalin, gabapentin, duloxetine, or a TCA. Keep in mind that patients with diabetes are at increased risk of all kinds of infections. This includes malignant otitis externa and fungal rhinosinusitis, which develop in immunocompromised patients as well. And finally, the macrovascular complications. Patients with diabetes are at increased risk of atherosclerotic cardiovascular disease, including coronary artery disease, cerebrovascular disease, or peripheral arterial disease. Coronary artery disease is the #1 cause of mortality. Management of atherosclerotic cardiovascular disease revolves around improving the underlying risk factors. That means glycemic control, blood pressure control, and lipid control. Any patient with atherosclerotic cardiovascular disease should be on aspirin as well.
Gabba!
Oh, hi there, little one.
Gabba! Gabba!
Okay,
Gabba!
Ow! What the?
Gabba! 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 Gabba!
Okay, you're supposed to be treating pain, not making it worse.
Gabba! Gabba! Gabba!
Ow!
Gabba!
What the frick? Be gone, devil child!